Good afternoon, everyone. I would like to welcome you to the Young ESPID debate on congenital infections. And we will start with an introduction by the Young ESPID board representative, Dr. Lily Verhagen, who is not here with us, so she will be by Zoom. Lily?
Yes. Can you hear me?
No, we cannot hear Lily.
I am here. I'm not sure.
Yes, we can hear and see you now.
Ah, great. Thank you. Yes, I can see myself on a very big screen now as well. So welcome all to this ESPID debate session. Welcome to everyone that is present in Athens, and also to the very high number of virtual participants that are joining us from all over the world. We actually have more virtual than physical attendees this year, which is both challenging and exciting at the same time. My name is Lily Verhagen. I am a fellow in pediatric infectious diseases and immunology, mainly based at the Radboud University Medical Center in Nijmegen, the Netherlands, but also spending 1/3 of the year abroad, working on the mucosal immune response and respiratory tract infections in pediatric risk populations. And I'm currently based in the Caribbean and the Americas and was therefore unable to travel, unfortunately. But happy to be here this way and to chair this session together with Raluca, my Young ESPID co-board member, and Fani, previous Young ESPID board representative and also one of this year's Young ESPID LOC members. Further, a special word of thanks to Karen Burgess from FitWise, who has really been supporting this session and us over the past years and will join a much deserved early retirement after this conference. Just a short background about the debate sessions. We started with these sessions as a Young ESPID initiative in 2019 in Ljubljana, Slovenia. And we continued during our virtual conferences with very creative sessions that were a mixture of role-playing, homemade videos, virtual polls, and live improvisation. Thereby really, I think, providing the physical and the virtual audience with a different experience from other sessions in the program. And as we have organized these sessions, we have also shaped them. And this year we decided to have 2 debate sessions, both of them combining an expert lecture with 2 debates by 4 Young ESPID members to really put the debates in a bigger perspective. Also new this year is that debaters are joining remotely and live, which actually turned out to be an opportunity to think even more creatively, I think. So today is the first session, and we will have another one tomorrow. And we will end the session with a 15-minute Q&A with all the speakers present. Then a few housekeeping messages. Please vote and send questions via the app. So go to this session via the program in the conference app and then use the platform to vote or send your questions during the Q&A, whether you are in Athens or whether you are online with us. And they will be visible to the meeting chairs that are there on their iPads. We will not have a Q&A in between, but we will have a Q&A with all the speakers at the end of the session. On to this debate today, and personally, I think there's probably no one better than Hermione Lyall to kick off this first debate session with her lecture on congenital infections, mainly syphilis. She is a consultant in pediatric infectious diseases at Imperial College Healthcare NHS Trust and an honorary senior year lecturer at Imperial College. She runs both HIV and other congenital infection clinics at St. Mary's in London. And in addition, she's an exceptional educator, and I've really had the opportunity and the pleasure to personally experience that when visiting St. Mary's some years ago. And she's been very active in numerous positions within ESPID. And I think she's thus very well placed to provide this first lecture, which will then be followed by the 2 debates. Those will be introduced by one of my co-chairs on site. So without further ado, I'll give the floor to Hermione Lyall to present her first lecture, and I'm looking forward to a very exciting session.
Okay, thank you very much, Lily. I hope you can hear me all right. I think my voice is a little bit hoarse, and that is because I have recently had COVID. That's my only disclosure. But I do not believe that I am infectious anymore. And, you know, this is the new world. We've all got to have COVID now. So We're starting off with syphilis. This is going to be a very rapid run-through. I've got 20 minutes, and Fanny is going to stop me at 19 minutes. But I just want to always remind you, and I love the title that you gave me, by the way, difficult to diagnose but easy to treat. And that is the bottom line about syphilis. And S in Scorch is for syphilis because it is the one that people always forget about. You get really into it with the torch screen. Forget about the torch screen. Now it's all about the Scorch screen. And in fact, don't ever let anybody say, oh, send the serology for congenital infections. That's the wrong way to do this. The way to do this is to think about, what does this baby in front of me have? What systems are involved? What infections might be involved? And then think about, what are the diagnostic tests that I need to do? So let's get away from torch and get into Scorch. So syphilis, if you think about it worldwide, is still a really big problem. But the highest burden of disease is in sub-Saharan Africa. There are still more than 500,000 cases a year. And it's not just a question of babies being born with syphilis, but it's actually the adverse outcomes, the spontaneous abortions, the stillbirths, and the neonatal deaths. This is a really nasty pregnancy infection. And it's much more prevalent than babies being born these days with HIV. And unfortunately, there are still parts of the world where syphilis is increasing rather than decreasing. The WHO has had a global approach to syphilis for many years now, and the targets that were set back in 2007 were to have more than 95% coverage of testing as early as possible, and less than 50 cases per 100,000, or a half a case per 1,000. But you can see that in 2017 and 2020, when people have been reviewing this, the coverage is still nowhere near what it needs to be. And of course, I've no doubt that the effects of COVID on this will also have been detrimental. There's a great deal of work. You know, we all know about lateral flow tests now. They are just part of our daily lives. And this is a beautiful dual test, but actually WHO is aiming for elimination of HIV, syphilis, and hepatitis B. So they have designed a triple rapid test to test as many women as possible in the first trimester. And I think, you know, this is really the way we need to go. The WHO definition includes all the adverse birth outcomes, so that is really important. And you can see here from the graph how the region with the highest burden is definitely Africa. But it also includes what they call non-clinical congenital syphilis. So these are the babies who are born with syphilis but look completely normal and are at risk of subsequent disease. And we'll come back to them because they actually are a very considerable number. So this is data, this is the WHO European region data, and you can see on the y-axis here, it's up to 2 cases per 100,000. So you can see that in our part of the world, if you happen to be in the European region, actually congenital syphilis is a very rare condition. And that actually makes it more difficult for us because we're likely to miss it. This is old data from the UK, which showed you what was happening during the Second World War, then what happened once we got penicillin, and then what happened after 2000. And what happened after 2000 was, as HIV became a treatable condition, men who have sex with men started to have condomless sex again and started to become infected with syphilis. And you can see alongside that a very slight rise in the female population as well. But in the UK, syphilis in pregnancy is a rare condition. You can see just between 1 and 2 screen positive per 1,000 women, and actually the number that needed to be treated was only half of that. We had a recent review of congenital syphilis cases in the UK, and you can see here that it was anything between 1 and 9 per year. Only 24 of those were confirmed cases. Very importantly, one of those babies was born to a mother who was screened when she presented in labor. So always remember that unbooked woman who presents in labor, you have to test her, not just for HIV, but never forget syphilis and hepatitis as well, because there are things we can do to prevent that baby from either being infected or from becoming unwell. In the UK, the majority of women are young women, and the majority of them were women born in the UK. And most, or at least more than half of them, were women who had significant other complicating issues going on in their lives that made them more at risk of becoming infected with syphilis. So, just to remind you, Treponema pallidum infects locally. You get primary syphilis, you then go on to get dissemination secondary syphilis, you then go on to get latent syphilis, and that may either remain the situation or eventually go on to tertiary syphilis. Syphilis in pregnancy, if you are infected for the first time in pregnancy, there's more or less 100% transmission and a very high risk of a severe adverse birth outcome. For some reason, syphilis really likes the placenta, and it can go across to the fetus at any time during pregnancy. There's a higher risk of prematurity and growth retardation. So all women need to be screened as early as possible. Women who are at high risk should be offered a second screen in the 3rd trimester. And of course, remember the unbooked woman in labor. Now, everybody gets into a bit of a tizzy about syphilis serology, but you really don't need to. There's the non-treponemal and there's the treponemal. And the non-treponemal, I always think of this like these treponemes are busy burrowing their way into blood vessels, releasing cardiolipin, and that is why you get the anticardiolipin antibodies, what we know as the VDRL or the RPR. On the other hand, we have the actual anti-treponemal antibodies, which are the antibodies to the spirochetes themselves, TPPA, TPHA, or the EIA. And if you've been infected with syphilis early on, you will make IgM. You will then make the non-treponemal antibodies, and the very important thing about the non-treponemal antibodies is that when syphilis is treated, the RPR and the VDRL will disappear, and that is what helps you to know that you have effectively treated the individual. On the other hand, if you've ever had syphilis, your treponemal antibodies will always be detectable, so they will stay there. But watch out for the false positives. So Treponema pallidum has pallidum, and all its other 4 subspecies. So there's Pinta, Begel, Yaws, etc. There are other spirochetes like the Borrelias. So you may have false positive treponemal tests. But more commonly, we actually see false positive non-treponemal tests, which may be due to autoimmune diseases, other infections, malignancies, or indeed pregnancy itself. So we have to watch out for the false positives. So we have to do that interpretation of what does the serology mean, and it's not always a static thing, it's also how are things evolving. What test did that mother have in the first trimester? What serology did she have after she was treated? What is the paired serology at birth? So it's not necessarily static, it's evolution and watching what is happening. A newborn who is IgM positive has got congenital syphilis. But watch out, because babies are not always terribly good at making IgM, so the lack of IgM does not exclude treponemal infection in the newborn. What sort of things might increase or decrease the risk of a baby being infected? So as we said, primary or early maternal infection. But if the mother has been treated, or if she hasn't not been treated, or if she's been treated with a non-penicillin regime, or if she was only treated in the last few weeks before the delivery, all of these things will put the fetus and the newborn more at risk. So you might have a symptomatic neonate, and you're going to be worried, could this be syphilis? But on the other hand, could it be CMV, or could it be toxoplasmosis? You've got to actually be taking in the whole picture to try and work out what might be going on. And the crucial thing is to get the right samples and get them through as quickly as you can to help to get the answer. Now, this is a story that some of you may have heard from me before, and I apologize, but it's a good example. Here's a little baby, 2 weeks old, comes in really sick, lactic acidosis, progressively unwell for the last 5 days, with respiratory distress and a blistering rash. There's nothing in the history of the pregnancy or anything else that we're worried about. You can see here this baby's on oxygen, and you can see that vesicular lesion on the eyebrow and an ulcerating lesion on the lip. The baby's got a CRP of over 100, lactic acidosis, abnormal sodium, abnormal liver function, a low hemoglobin, a very high white count, low platelets, normal CSF, abnormal chest X-ray. So for a 2-week-old baby, that is a very wide differential diagnosis. So, you know, I love the differential diagnosis. So keep all these different things in mind. But could there be something else? Well, here are the feet. If you see a little baby with a really thick desquamating rash, that is almost pathognomonic of congenital syphilis. And if you see a little ulcerating lesion or a vesicular lesion, that could be human herpes, it could be human HSV. But on the other hand, you can stick a slide onto that lesion and get the answer straight away without having to send away the serology. So dark phase microscopy of the liquid from those blisters was teeming with spirochetes. Now, the mother hadn't been anywhere, but this dad had been on a business trip to Russia, and he had come back, and this poor woman, not only had she acquired syphilis, but unfortunately also hepatitis C. So, travel history, not just the individual. So, difficult to diagnose, easy to treat. So we talked about the rash. A baby with high drops, always think of syphilis. A leukoerythroblastic blood picture, high white count, low white count, low platelets, low hemoglobin, think of syphilis. This is a baby who had thrombocytopenia, a massive intracranial bleed, and secondary hydrocephalus due to syphilis. This is a baby with hepatosplenomegaly, often a conjugated hyperbilirubinemia. And this is a baby where the family were referred to the safeguarding team because the baby had a broken arm. But actually what this baby had was the most severe syphilitic osteitis and a pseudoparesis. So you've got to do your assessment of risk. And the high-risk infant, you're going to do that antibody screen. If you can get hold of the placenta, if it's a brand new baby, that is very useful. Also, if you're worried about congenital syphilis, you need to look for the spirochete and the serology in the CSF. You need to x-ray the long bones. It's always easy to treat. The treatment is easy. In the low-risk infant, though, it's not so urgent. If the baby is well, you can wait for the serology to come back. But what about the infant with a normal examination? So those babies who look fine. So you then have to make your assessment of whether there's no risk or there is still a risk. So if the mother's been previously treated and everything is going fine and there's no risk, new risk of reinfection, which is always a bit of an issue, then many would say you don't need to do anything for that baby. If the mother's been treated early on in the pregnancy and you've reviewed the serology and you know that her RPR has gone down and you're very happy about things, then you just need to follow up that baby serology and make sure that they lose all their maternal antibodies. On the other hand, if you think this baby may be high risk because the mother's only recently been treated, then you rapidly need to get your serology back and make a decision about whether or not treatment is required. And, well, the treatment is fine. It's been the same thing for the last 50 years or more. But always remember about the neonatal kidneys, that you have to change the dosing with the maturing of the renal function. Actually, nowadays, we don't use penicillin, we use ceftriaxone. It's much easier to give just once a day, and if the baby's well, they can actually be at home. There are no randomized controlled trials of ceftriaxone versus penicillin in the newborn, but the adult studies have demonstrated equivalent response rates. So I think that is a very good treatment. And the received wisdom is that if you have positive changes in the CSF, you should repeat the lumbar puncture at 3 to 6 months to make sure that the serology that the RPR has disappeared and that everything has gone back to normal, the protein is back to normal. The latest CDC advice says you don't need to, but I think many of us would feel reassured by that. So, we talked about the neonatal presentation. Don't forget Hutchison's triad. So Dr. Hutchison, who was working before we even knew about the spirochete, recognized the syndrome of late effects of syphilis, including the teeth, the eyes, the brain, and sensory neural deafness. And indeed, I think I saw my colleague Steve Walsh here in the audience, who in fact recently had a baby born to a mother who may well have had congenital syphilis and never been treated. So at those times, it was possible to get syphilis into the next generation. This is the last story. Is this late congenital syphilis? A mother is diagnosed in the first trimester of her second pregnancy, gets treated, everything is fine. But the pediatrician says, well, we better test the last baby. The 3-year-old is absolutely fine, but you can see this baby has had syphilis, is TPPA positive. The RPR is low, the IgM is negative. What does that mean? Well, in fact, this little baby had been admitted to hospital at 10 days of age with sepsis, but did have hepatosplenomegaly and did have slightly low platelets, was treated for 10 days with ceftriaxone, no positive cultures, no samples left to test for syphilis in retrospect. But I think the bottom line here is that that baby had congenital syphilis and was treated. So septic baby, we heard earlier this morning, always think of herpes simplex, but remember syphilis too. So the WHO is working really hard to eliminate syphilis in the places where it really matters. And that is a very, very important, enormously important effort. For us, it remains a rare condition, but remember the symptoms and signs. It should be there in every differential diagnosis, and remember the right tests to do. And you need to work together with your obstetricians, with your neonatal colleagues, and we need to bring all our findings together. So thank you very much, and I'm looking forward to the debates.
Thank you so much for your talk, which was very interesting as usual. So we will leave the questions for the end, and we will go straight ahead to our first debate from the young ESPID members Naomi Kirk from North Ireland and Clara Carreras from Spain, who will debate on the topic premature infants born at less than 30 weeks of gestation should not receive expressed breast milk because of their risk of contacted CMV infection. And the floor is yours.
Well, hi everyone. So we'll start with a few questions. So if you can have your app ready, we'll start with question 1. Oh, shit, I cannot. Okay, question 1. Express breast milk, EBM from now on, from CMV seropositive mothers should be given to 1. All infants admitted to NICU. 2. Infants greater than 30 weeks gestation. 3. Infants greater than 30-week gestation and greater than 1.5 kilos. 4. No infants should receive EBM. Please vote now. I think we have 45 seconds. Hope this works. Okay, so most people answered that EBM should be given to all infants admitted to NICU. You are from my team, and we'll see what you think after the debate.
So
please
close the voting. Yeah, so answer to be determined at the end. So question 2, what percentage of CMV seropositive mothers transmit CMV to their infant through breast milk? So 1, 5 to 20%, 2, 20 to 40%, 3, 40 to 50%, or 4, up to 60%. So if you vote now. Okay, so most people going for 5 to 20%, so let's see the answer. So 4 up to 60%, so it does depend on the literature, but some studies suggesting anything between 40 to 97%.
Question 3. Regarding postnatal CMV infection, which statement is incorrect? 1. Mostly all infants are asymptomatic. 2. Preterm and low-weight infants are at higher risk. 3. It's a common cause of hearing loss. 4. Antiviral therapy is not well established. You can vote. Yes. The incorrect answer is number 3, as it's not a common cause of hearing loss. This is actually common in infants with congenital CMV, and multiple studies have shown no association between postnatal CMV infection and hearing loss.
Okay, so we're going to start with a really quick case report just to set the scene for the debate. So, male twins born at 29+4, elective C-section for severe preeclampsia, and steroids were given antenatally. Maternal serologies were negative for rubella, HIV, Hep B, syphilis, and toxoplasma, and Group B strep was also negative. Serology for cytomegalovirus or CMV was not performed. Twin 1 was born, good birth weight and good condition. Twin 2, however, was 748 grams and had respiratory distress syndrome. He required CPAP for 18 days and then high flow. Feeds were introduced slowly with full feeds by day 12. A screening swab, saliva PCR for CMV on day 2 was negative. However, he deteriorated on day 37 with apneas, tachycardia, distended abdomen and bloody stools requiring intubation and ventilation. His abdominal X-ray was suggestive of necrotizing enterocolitis. Antibiotics were commenced and feeds were held.
So, bacterial cultures came back negative, so antibiotics stopped on day 4, and CMV was detected in urine and blood, as well in the breast milk of the mother, being the likely cause of infection. Twin 1 was also found to be infected, but asymptomatic, and treatment with IV ganciclovir was given for 4 weeks because of the severe abdominal symptoms and persistent thrombocytopenia. Feeds were reintroduced after 10 days with donor milk, and 3 weeks later the patient presented with bilious vomiting and abdominal distension. Feeding was changed to highly hydrolyzed milk, but was poorly tolerated. Thus, an opaque enema was performed, suggesting stenosis of the ascending colon, requiring surgery which confirmed multiple colonic stenosis. An end-to-end ileosigmoid anastomosis was performed, and feeding restarted 4 days after the surgery. Pathology findings confirmed the CMV infection, and the patient was discharged 4 weeks after surgery, thriving on oral feeds with a normal clinical examination.
Okay, so now we're going to watch a short video of a follow-up consultation. So the mother of the twins is meeting with the neonatal consultant. She's been doing some reading and has some questions.
Thank you for meeting with me today. I've been thinking through my son's care in the neonatal unit. And I'm a scientist, so I've been doing some reading and research of my own. My son was extremely unwell with postnatal CMV, and from what I've been reading, I think it was avoidable. I don't think the neonatal unit should be giving express breast milk to these very premature babies. If this policy had been in place, as it is in other units, then my son would never have become so unwell.
It's my pleasure to meet with you, and I'm happy your son's doing well since discharge. We can discuss this further, and perhaps you could let me know some of your reasons for this opinion, and I can try to respond.
Well, it's clear that babies less than 30 weeks already face so many challenges in relation to respiratory disease, sepsis, risk of hemorrhage. Why are we exposing them to an additional risk? I read that many women are seropositive for CMV, and up to 80% of women who are seropositive will secrete the virus in their breast milk.
You're right about the higher risk of transmission in preterm and very low birth weight babies, but the numbers of infected infants acquiring postnatal disease are small compared to the numbers that could benefit from breast milk. So although the risk of transmission is high, symptomatic disease and severe disease will occur in very few babies.
Yes, but although these numbers are small, for the families involved, it is significant. My son was really unwell, and it was an incredibly stressful time for us. Furthermore, I think it's even more significant given that I know it's preventable.
I'm deeply sorry about what happened to your baby, but as I said earlier, most infants infected with CMV will be asymptomatic or mildly affected like your other baby. And we're actually convinced of all the benefits that breast milk provides, including decreased rates of late-onset sepsis, necrotizing enterocolitis, retinopathy of prematurity, or neurological outcomes, among others. But we actually have this same debate in the scientific community.
Yes, indeed, and I was counselled about all the benefits of VBM, but there were some things I wasn't told. For example, breast milk alone often isn't enough to meet the nutritional needs of the infant, and fortification is required, which has side effects of its own.
Fortification may be used, but there's no doubt that breast milk provides more benefits than formula. In addition, long-term benefits of breast milk have shown that babies who are breastfed present lower rates of obesity later in life, as well as lower rates of food allergy, eczema, asthma, celiac disease, and diabetes, among others.
Yes, but do the benefits of breast milk really outweigh the risks of postnatal CMV? These babies become very unstable, and anything that causes instability increases the risk of other complications. Postnatal CMV is a risk factor for bronchopulmonary dysplasia, necrotizing enterocolitis, longer mechanical ventilation, and delayed discharge.
We have to take into account that these patients are preterm and very low birth weight babies, also risk factors for the complications that you are describing. Regarding NEC, only a small proportion are caused by CMV infection, and it has a multifactorial cause, generally related to the immaturity of the intestinal barrier, genetic factors, the introduction of enteral feeding, and an abnormal bacterial colonization, among others. In addition, it has been shown that breast milk is protective against NEC. There are also opportunities to reduce the risk of CMV transmission, but continue breast milk, such as pasteurization and freezing milk. Pasteurization is highly effective at removing viable CMV, and refrigerating and freezing milk are also an alternative.
Yes, but refrigeration and freezing are less effective than pasteurization in removing CMV, and pasteurization removes many of the protective and good constituents in breast milk. If we're removing many of the reasons why we're giving breast milk in the first place, then why not just give a formula that can meet the infant's nutritional needs at a lower volume?
No. For these reasons, we continue to recommend the Tridazone mother breast milk as it has more benefits. It strengthens the baby's immune system and may help your baby fight disease and infection. It also contains growth hormones that help your baby grow, and human milk is actually easier to digest than most formulas.
I read on the internet that the American Association of Pediatrics suggests considering serological screening of mothers for CMV less than 32 weeks. This wasn't offered or discussed with me. If I'd known I was CMV seropositive, then I may not have wished to provide my milk.
This is actually a reasonable option to consider, but it means withdrawing breast milk from many children who would not become infected or wouldn't develop the disease. Furthermore, for those infants who do become unwell, we do have the resources to treat them.
Yes, but now you mention treatment. So my son wasn't treated initially due to a concern about side effects. From my reading and conversations at the time, I understand there is limited data on dosing and short and long-term side effects, never mind the risk of carcinogenicity and germline damage. Surely in this instance then, when there's no gold standard for treatment, it is better to avoid in the first place.
It's not uncommon in pediatrics not to find randomized clinical trial multiple treatments. For the reason we have to individualize each case as we do in many other diseases. In the case of your baby, we decided to treat him because he presented with severe intestinal manifestations and persistent thrombocytopenia. Thus, the benefits of treating were better than those of not treating. I'm happy that he recovered well and is now thriving, but in any case, I will transmit your thoughts to my colleagues and the scientific community to discuss this with them.
Okay. So you can see the debate with the mother of this infant who was very ill. However, I am convinced that our policy is correct in continuing to give breast milk to all infants.
Well, actually, she raised many good points, and I'd have to agree with her. So the global seropositivity for CMV is around 80%, and at least 80% of seropositive mothers will secrete CMV in their breast milk. So this means that really most mothers are secreting CMV. Transmission rates can be as high as 59% from mother to infant, and around 23% of infected infants are symptomatic of acute CMV, and these infants are usually extremely premature and low birth weight.
Although some studies show transmission ratios up to 60%, symptomatic postnatal CMV disease will occur in about 3.7% of cases with a severe sepsis syndrome in less than 1% of infants. In addition, although the usual source of infection is breast milk, it can also be acquired from other sources, such as the birth canal and other ways of horizontal transmission.
Well, in the UK, around 3,000 babies are born less than 28 weeks each year. So this could potentially mean around 100 babies symptomatic from postnatal CMV. Seroprevalence of CMV is also higher in women of lower socioeconomic status, which is in itself a risk factor for low birth weight and prematurity. So this is an example of health inequality where there's an increased risk to the more vulnerable babies.
Yes, very premature neonates may be susceptible to postnatal CMV, but at the same time, they are also protected by their mother's breast milk, as it provides additional support for the immature immune system of the neonate. So would you withdraw breast milk to all infants who may benefit from it, that won't probably be infected or develop the disease?
Well, is breast milk really as great as you say? So even EBM at 180 to 200 mils per kilo per day often doesn't provide enough calories to support the optimal growth of a preterm infant, and additional fortification is added, which can have side effects of its own. And we all know that extra uterine growth restriction is a serious problem for these infants. Also, the most common symptoms of infection are essentially similar to those associated with late onset bacterial infection. And episodes of sepsis in premature infants are associated with increased respiratory support, risk of hemorrhage, and poor growth. Never mind the use of antibiotics, as most babies will be started on these antibiotics initially. Apart from the individual impact this can have on the microbiome and side effects from the antibiotics themselves, it also has a role in antimicrobial resistance.
But once cultures come back negative, antibiotics should be stopped to avoid an impact on the baby's microbiome and antimicrobial resistance, as you were saying. And in addition, the bacteria present in breast milk have a relevance as drivers in the acquisition of healthy microbiota. And I insist that it's all a matter of balancing the pros and cons of giving breast milk, as breast milk has shown to prevent late onset sepsis, the use of antibiotics, and also days of NICU hospitalization.
Okay, but you can't argue that the timing of these infective episodes isn't important. So looking at the viral content in EBM over time, CMV is detected at maximum levels around 4 to 8 weeks. So for a baby born less than 30 weeks, this is a time when they're just starting to stabilise. So it's a big setback for them to become unwell again. As well as the physical illness, this has considerable emotional and psychological distress for the families. Any additional complication that can cause a prolonged stay in NICU shouldn't be taken lightly, as we know that these are risk factors for future maltreatment and non-accidental injury. Because if a baby becomes unwell with postnatal CMV, this reduces opportunities for skin-to-skin and interrupts the parents forming that essential bond with their baby.
Yes, but nowadays developmental care is maximized in NICU, even in seriously ill neonates, and breast milk also confers many psychological and environmental benefits for both mother and infants, as well as increased bonding between them.
Okay, but what about the longer term? So in a study considering symptomatic preterm less than 32-week infants with postnatal CMV, 24 infected infants were considered, so 14 developed a sepsis-like syndrome, and there was increased home oxygen at discharge across the affected infants.
Yes, many studies, such as Takemoto et al., have shown no significant neurological outcomes at 18 months and 3 years of age. And that's true that larger studies with long-term follow-up are needed for a better understanding, although there's no evidence to date.
So they didn't find a significant difference in the two groups in relation to the neurodevelopmental impairment, but the CMV group did appear worse, with 29% impairment versus 17%. As the mother stated earlier, we should be cautious in the term significant. As a parent, if your child would fall into that additional 12%, then it would indeed be significant for you and your family.
Yeah, that's true that further research is required, but we know that significant benefits of EBM is provided. Interventions to remove CMV from the breast milk of seropositive women is possible, but may also damage other important constituents of the milk. This requires also established CMV screening in pregnant women and/or babies at birth. So changes in practice cannot be recommended until further studies have defined the risk-benefit ratio of such strategies. And at present, I think that the benefits of breast milk outweigh the risk of postnatal CMV.
The bottom line is, though, that symptomatic postnatal CMV infection is a serious concern for affected infants, and I would argue it's probably more common than we think, as many infants with a sepsis-like syndrome won't be investigated for postnatal CMV. Up to a fifth of premature infants will develop symptomatic postnatal CMV, and there's no consensus on treatment, and long-term side effects are unclear. Furthermore, it is preventable by avoiding EBM in the most vulnerable infants or with seropositive mothers. Although EBM does have many benefits, I would argue that in this cohort of infants, it's not as clear-cut. They may not benefit nutritionally from EBM, and nutrition is a key factor in their development. We also have many options in relation to infant formula. We don't need to stop these infants from breastfeeding. We can encourage mothers to express, but we can avoid giving EBM until they're more mature. When giving EBM at this gestation, we are introducing a known risk to these infants, and as Hippocrates first said, first do no harm.
Well, we'll see if you change your mind or you still think the same.
Yeah, so we're going to go back to question 1. So express breast milk should be given to 1, all infants admitted to NICU, 2, infants greater than 30 weeks, 3, infants greater than 30 weeks gestation and greater than 1.5 kilograms, or 4, no infant should receive EBM. Vote now. Yeah, so perhaps unsurprisingly, breast milk still wins the day. And Effie, I think that's us, yeah, 82%.
So we'll leave the questions for the end.
Yeah.
Thank you very much. Now we are welcoming our second debaters, Nisreen Khambati from UK and Asrar Abu Bakar from Malaysia. As this is a hybrid congress, this will be a hybrid debate. The name of the debate is Asymptomatic Baby with Congenital Toxoplasmosis, and the question is to treat or not to treat, and and for how long, actually.
Thank you. Next slide, Asra. We have nothing to disclose. No. So, it's a Wednesday evening at a busy tertiary hospital, and the paediatric doctor on call receives a call from a worried midwife.
Hello, it's Dr. Ali, paediatric doctor on call.
Why, good evening, doctor. I need some advice about a baby. I have a mother who recently moved here from Brazil. She delivered a baby, a female baby, at term via emergency section this afternoon. Now, most of her antenatal care was actually done in Brazil. And after going through her notes, the doctors noticed that she was positive IgG and positive IgM for Toxoplasma gondii during her last trimester. It was part of a screening over there. So I'm denies any treatment in Brazil as far as we are concerned.
Okay, so it sounds like mother's serology is suggestive of toxoplasmosis. What's the condition of the baby like?
Now, as far as we're concerned, the baby is doing quite well. The pediatric doctors actually went to see the baby after it was born, examined the baby. There was no rash, no hepatosplenomegaly, no microcephaly. They also did a cranial ultrasound scan, which was normal. And as far as we're concerned, when we look at the notes, even the fetal ultrasound scan was normal. So the baby is quite good.
Okay, so we need to take some diagnostic bloods from the baby, in addition to paired samples from the mother, and we need to ask the ophthalmologist to urgently review the baby. But so far from what you're telling me, this baby is asymptomatic.
Oh, so sorry. Yes, exactly. Mom has actually looked up about congenital toxoplasma on Google, and she's very afraid. She's worried that her child might be disabled. Do we need to start treatment on this child?
Yeah, I'm not really sure. I mean, looking at our hospital guidelines for congenital toxoplasmosis, the indication for starting therapy is end organ disease, which so far this baby doesn't have. The good news is we have a neonatology pediatric infectious disease multidisciplinary meeting in the next couple of days, so we can ask the experts.
Okay, do get back to me as soon as possible, yeah?
So we're now going to come on to our questions. So to start it off, for question 1, for a baby with asymptomatical congenital toxo, would you give postnatal treatment? 1 for yes or 2 for no? Voting open. We might not be able to see the results because Asrar is sharing the screen. Okay, we can go to our second question. So, if you were to give treatment, for how long would you give? 1 month, 3 months, 6 months, or 12 months? So, if you were to give treatment, for how long? Toss up between 6 months to 12 months so far. Okay, so 6 months for the majority at the present. Okay, moving on. 1 week later, welcome, everyone, to the weekly neonatal PEDS ID MDT. Thank you very much for joining us. My name is Dr. Khambati. I'm a consultant neonatologist here with an interest in ID. We also have Dr. Asrar Abu Bakar. He's our PEDS ID specialist. Now, unfortunately, Dr. Asrar, he couldn't make it today because he's on holiday, but being the very devoted consultant that he is, I think he'll be joining us virtually. Dr. Asrar, can you hear us?
Oh, hello, everyone. I'm sorry, I hope you can see me. Good morning, Dr. Khambati. Nice to be joining you in this MDT. I'm actually technically at work. Sorry for my sunglasses. I'm actually in Greece for an ID conference, but as you can see, I'm actually taking a little break at the Acropolis. It's amazing stuff. You should come and visit, really.
Well, we're all in a conference room, so thanks very much for that. Anyway, I think we should crack on. So we have an exciting case to discuss. So we have a 1-week-old female neonate from Brazil with congenital toxoplasmosis based on significantly raised antibody titer in the infant. Now, the infant has a normal physical exam. The ophthalmologist review was normal, and the MRI brain was reported as unremarkable. We're still waiting for PCR of the CSF, but so far we think that this infant is asymptomatic. So, do we treat this infant?
All right, okay. Thank you for that nice summary, Dr. Khambati. But in response to your question directly, I would argue against treating this child, and I will tell you why. Although we know that the probability of this child having congenital toxo is pretty high, as we know that seroconversion at the last trimester carries a higher risk of transmission compared to earlier trimesters, as nicely shown in this graph. However, if you look at the data with regards to seroconversion in the third trimester, the chance of having symptoms or severe disease in childhood is pretty low. Therefore, in a child who's asymptomatic on the onset of diagnosis, I think we can wait before we actually treat this child.
No. Unlike you, Dr. Asrar, I actually strongly believe we should treat this infant. Now, it is true that many babies with congenital toxoplasmosis do not have symptoms at birth or in the early days, but many can still go on to develop clinical disease later on. In a study in 1986 published in The Lancet, 7 congenitally infected toxoplasmosis infants with no symptoms at birth were followed up for 20 years, i.e. into early adulthood. On follow-up, 4 out of these 7 children developed retinal eye lesions, and in some cases, impairment was severe. In another study, this time in 1980, they followed up 11 infants with congenital toxoplasmosis. Again, no symptoms or signs of disease at birth, and again, no treatment given. On follow-up, the majority of these babies developed neurological complications, and most of these were severe, including hydrocephalus and seizures. With this in mind, the benefit of treatment is that it helps prevent these long-term delayed adverse sequelae. Now, what's the evidence for this? I can already hear Dr. Asrar asking me this. Well, the truth is, the evidence we have is limited. We have no randomized control trials, and instead, the evidence comes from large observational cohort studies. One such very important study was the National Chicago Study. Now, this study looked at outcomes of treatment with pyrimethamine and sulfadiazine in 120 congenitally infected infants between 1981 to 2004. Of interest for us and our baby, there were 24 infants within this cohort that had no or mild disease. On follow-up, they found that 0 had any abnormal neurological or hearing outcomes. Only 8% had new eye lesions, and there were no deaths. Now, obviously, because outcomes were so favorable, a placebo-controlled trial would have been deemed ethically contraindicated. So instead, the authors compared this treated cohort to previously historic untreated controls from previous decades. And they found that for nearly all the study pre-specified endpoints, treatment led to better outcomes. So I do believe, yes, we should treat this asymptomatic infant to prevent these long-term later sequelae.
Well, you really did your homework, didn't you, Dr. Khambati? I mean, while I applaud your efforts in trying to convince us, I think you quite rightly said there is simply lack of evidence. I mean, the Chicago study that you mentioned compares more recent cohorts with those cohorts from earlier decades. I mean, dating as far back as 1960s. So, of course, there will be differences in outcomes as medicine progresses down the years and treatment becomes more readily available. I mean, we just simply cannot compare apple for apple here. I mean, to put things into context, I mean, those children back then who were asymptomatic might not necessarily be asymptomatic today, as we had better equipment to detect abnormalities such as neonatal ultrasound scans, MRI scan machines, that we only started familiarizing post-1980s. So I bet you those historical cohorts who we define as subclinical or asymptomatic back then might actually have subclinical disease that had gone undetected and hence presented with complications later on. But let's just look back at that Chicago study that you mentioned again. I mean, you clearly mentioned that there are 24 infants in the no to mild disease group, but what you failed to mention, Dr. Khambati, is that out of those 24, only 12 were truly considered asymptomatic and had no disease. I mean, don't you feel there's an underrepresentation of asymptomatic cohorts here? Surely we need to look at more data on long-term outcomes. In short, I think there is simply no strong evidence on the effectiveness of any postnatal treatment strategies as highlighted by this superb article by the American Academy. So what we need now is actually, as highlighted by this European review, is to design a randomized double-blind controlled trial. But because the disease prevalence has actually fallen in many countries, I think recruitment to children in any future studies will be quite limited. What we also need is actually data on disease burden, which I think is scarce at the moment.
Well, thank you very much, Dr. Asrar. I'm glad you mentioned disease burden. So one way of measuring disease burden, as we all know, is disability-adjusted life years, otherwise known as DALY. Now, DALYs represent the number of years lost due to ill health, disability, or premature death. Now, in 2010, in the European region, toxoplasmosis led to nearly 73,000 DALYs. And to put that in context for you all, that ranks third in all foodborne hazards that year. And just going back to treatment, well, I think that actually treatment could actually affect quality of life. In a study in France, published in the PIDJ, they looked at 102 babies with congenital toxoplasmosis. Now, the vast majority of these babies were treated. Of interest to us and our asymptomatic baby, a significant proportion of this cohort did not have any end organ disease. 40% had no eye lesions and 88% had no neurological lesions. Now, when they followed up these babies into adulthood, they found that quality of life scores in this treated cohort was equal, if not similar, to the general population quality of life scores. Now, of course, unfortunately for us, the authors didn't give a separate analysis for asymptomatic children. However, to me, I say it looks positive. Don't you think, Dr. Asrar?
Okay, Dr. Khambati. I mean, while I acknowledge that treating children with congenital toxo did lead to some reductions in comorbidities and also death, I still feel strongly against subjecting an asymptomatic child to undifferentiated treatment. I mean, we all know that this particular drug has significant toxicity from our long years of experience on treating malaria. I mean, take a look at this old study, for example, where they identified significant portion of patients with anemia, with neutropenia, and also low platelets. But when it comes to studies in children, this systematic review has highlighted the serious adverse effects of pyrimethamine-based therapies in up to half of the studied children. Out of those, neutropenia were counted up to 45.8%, while anemia was also reported in up to 50% of the studied cohorts. I mean, I don't think we can simply ignore these data and to subject those risks to an asymptomatic child when evidence is poor is indeed causing more harm. I mean, don't you think, Dr. Khambati?
I mean, Dr. Asrar, I can't deny that pyrimethamine can have toxic side effects. Okay, yes. But the question I think we should be asking is, how do we manage it? Okay, so we do have something called folinic acid. This counteracts against the bone marrow toxicity of pyrimethamine and therefore can help prevent the associated neutropenia. If neutropenia occurs during the course of the treatment, well, you can increase the dose. And if you really need to, you can temporarily hold the pyrimethamine. I do think that we need to put the toxicity in context of the seriousness of this disease. Let me remind you that this infant comes from Brazil, and we think that toxoplasmosis strains in South America tend to be more aggressive. I'd feel very nervous about not treating. And to me, the irreversible neurological and eye complications far outweigh the potential side effects of treatment, which, with regular full blood count monitoring, with folinic acid, and obviously safety netting of parents, I think are more important.
Okay. I mean, while I appreciate your concern, Dr. Khambati, but we have yet to talk about treatment failure. I mean, I'm sure you've come across some studies where some children who were treated successfully end up having relapse of the disease, mainly eye complications, many years after successful treatment. I mean, so by all means, it's not the most effective treatment that we have. But rather taking a one-size-fits-all approach, I would prefer a conservative individual approach where we have to factor in the risks of severe disease, risks of treatment toxicity, and also to find out what evidence we have available currently. So in our case, I think we can delay the initiation of treatment and follow the child up closely. But something we do need to think about is that if we do take the conservative approach, I mean, how often should we review this child?
Sorry.
How often do we need to check the eyes, for example?
Sorry, Asrar, I think just hold on. We have a call coming. 1 second.
Oh, right. Okay. Sorry. Yeah.
Sorry to interrupt.
Excuse me, may I know what the plan is for the baby? Mom's just asking.
Sorry, Asrar, I think we better move on.
Yeah, that midwife looks very familiar, by the way. I don't know what you know. Okay, look, I think let's say we do decide on treating this child. I mean, how long would you treat her for?
I mean, Asrar, you know what I'm going to say. We don't have an easy answer for this. Data on duration of treatment is even more limited, even for symptomatic babies. I guess the best evidence we have for asymptomatic children, again, comes from observational studies like the Chicago study. Now, you remember those 24 infants with no or mild disease that had better outcomes? Well, all of these infants had treatment for 12 months. And actually, this 12-month regimen from the Chicago study has actually been proposed by multiple other toxoplasmosis centers studying cohorts in America, in Europe, and in Australasia. So I think, although, yes, not all of these babies will have been asymptomatic, I think 12 months is our safest option.
Come on, Dr. Khambati. I mean, don't you think 12 months of a toxic drug such as pyrimethamine, is it not a long time for a child who's asymptomatic? I mean, please remember that these medications, they don't exist in nice, easy pediatric formulations. And I think parents will struggle to administer them.
Okay. What we could do, potentially, is rather than continuing the daily intensive pyrimethamine for 6 months, as we would generally do for our symptomatic babies, we could stop the daily intensive phase after 2 months. Actually, in the Chicago study, they did look at comparative efficacy of daily intensive pyrimethamine for 2 months versus 6 months and didn't find a statistically significant difference. So it gives me confidence that we can do this. Obviously, though, just to say, the pyrimethamine should still be continued on a 3-time weekly basis to complete the 12 months in total.
I mean, is that the really best thing you can offer, a 4-month intensive phase discount? I mean, overall, I feel that 12 months is a big commitment from both child and parent. But let's think from the parent perspective for once. I mean, take a look at this study where it mentions a high level of anxiety among parents. Therefore, subjecting them to undifferentiated treatment will lead to more questions being asked on what we're actually treating. I mean, can you imagine the amount of stress to the child and parent for all the regular blood tests, visits that we have to subject them for treatment monitoring? I mean, take a look at this poor little girl, for example. I mean, thinking that she would come to have a pleasant visit only for her blood to be sucked out by the people she had trusted. I mean, we should really make the world a better place for her, don't you think?
Okay, where did you find that video from, Asrar? Anyway, what do you think we should do?
All right, okay, this is what I think we should do. I think we should be a bit more lenient in our duration of treatment. For example, from the Red Book, from the American Academy, they clearly recommend a much shorter duration of 3 months in asymptomatic children. And this goes along with some centers in Europe, including in Germany, where they recommended a much shorter duration depending on the severity of the symptoms, to as low as 3 months if the child doesn't have any symptoms at all. Unfortunately, we don't quite have any long-term data of those children who receive the short regimen, whether they end up doing well down the line. There was a Toxkin study that was currently in the pipeline, and they were looking at the outcomes between a 3-month regimen versus a 12-month regimen. Unfortunately, we don't quite have any data published yet from this study, but I suppose we should just watch this space, shall we?
Look, Dr. Asrar, I think we are actually running out of time. I think we need to come to a decision. What are we doing? Right,
okay. I mean, all in all, I stand firm in my opinion that the child of ours does not need any treatment. I mean, to me, the risks of any long-term outcomes can be managed by close follow-ups, and we treat only when we detect disease and when we detect any disease as we go along. I mean, this should also reduce unnecessary parental anxiety. Until we have stronger evidence, for example, from randomized controlled trials, I think we can argue very little on what we think is the best approach. In view of this, I think we should treat the child as a case-by-case basis, taking into account the symptoms the child has upon diagnosis, and also consider the potential harm of treatment in an asymptomatic child when we don't quite have the evidence yet.
Okay, well, Dr. Asrar, I really don't think that your approach of following up an asymptomatic child closely as an outpatient is feasible in many settings, particularly in low-resource settings where access to specialists like us may be less available and where facilities to detect this subtle subclinical disease may not always be there. I also think that for some families, not treating would actually raise parental concern. I agree with you regarding the limitations of evidence, but even if efficacy is not shown with RCTs, I believe the safest option is still treating for 12 months. Look, I think we aren't going to come to an agreed decision now, and I think you need to get back to your souvlaki. So we have lots of clever friends here in our MDT, so why don't we ask them again? So for question 1, for asymptomatic babies with congenital toxo, would you give postnatal treatment? Or, if you were to give treatment, for how long would you give it? Okay, poll isn't working, but that's it for us. Thank you.
Thank you very much for your exciting debate. I'm waiting for the technician to send me the votes, so probably you will know soon what the people voted, because we don't have the votes. But we can go meanwhile to your questions. Do we have any questions from the audience? Yes, please.
I'm Zeynep Ergenç from Marmara University School of Medicine, Istanbul, Turkey. Thank you for a great symposium. I would like to ask your opinion about the breastfeeding of the primary immune deficiency patients. Do you consider to stop breastfeeding, or do you recommend to continue breastfeeding in these patients?
Well, that's an interesting question, and obviously it's a pretty rare occurrence. But I think if you were worried, as we know, if a woman is CMV seropositive, she's very likely to have CMV in her breast milk. So I guess the question would be, at what stage have you made the diagnosis? And if you've made the diagnosis after 4 weeks of age, you know, it's quite likely that the baby may already have been infected with CMV. So is it going to, you know, what is the risk-benefit balance there? And of course, there are other infections that can transmit through breast milk. So you always have to remember about HIV, and you have to remember about HTLV1. Hopefully your mother has been tested for HIV, but maybe not for HTLV1. These are relevant to all babies, not just a baby who's born with a congenital immune deficiency. So I think it's going to be on a case-by-case basis.
Okay, thank you very much.
Hello, I'm Ariane, I'm from Liverpool. I have questions around the syphilis talk. I was wondering about the IgM testing. I did an audit a couple of years ago as a trainee and actually found that the IgM was often not there. We had a discussion with our local team around, why should we not do it? And I think at the moment it's actually at the discretion of the lab. So I think most of us as pediatricians will just ask for the serology and you either get an IgM or you don't. So I just thought, what were your thoughts of that? Should we be more proactive in adding that, or how do we get around the labs, maybe all following similar protocols?
So that's a really important point. Mostly in adult GUM, they no longer do IgMs for syphilis because it's not a particularly good test and it has false negatives and false positives. But I think the situation for the newborn is a little bit different. As I said, it isn't always there because babies aren't always very good at making it. But if you do have a positive IgM, then it definitely tells you that the baby's got syphilis. So I think it's still in the baby's interest to have the IgM result. And you're right, you have to ask for it. But it's in lots of clinical guidelines now, people are probably often not doing it. But to me, it still makes sense.
So just for the record, we have the results of the poll. In the initial question, whether we should give treatment to this asymptomatic baby, 43% voted for yes and 57% for no. And during the second round, after the debate, yes 40% and no 50%.
I'm sorry, Dr. Asrar, you didn't manage to change their views, but I'm with you.
Okay.
Maybe if I was there as a live person, maybe it would be, they would change their mind.
Okay. Do we have any other questions?
Yep.
Yes, please.
Hello, I'm Valeria from Italy, and I have a question about a lumbar puncture for syphilis, for congenital syphilis. It comes from a case that we handled in a hospital, and there was this baby born from a mother who arrived with, and she said that she contracted syphilis many years ago, but she was treated and everything was fine. She had no documents with her. So we did all the diagnostic workup for the kid, and we had the serology, and the serology for the baby, the non-treponemal serology was negative, the treponemal was positive, and we decided to do the lumbar puncture anyway for the kid, and I was wondering if that was a mistake. I mean, if it could have been avoided or if we did the right thing. It was negative at the end, but I was wondering that, if you would have done it.
Okay, so if the mother says she's been treated, that is always a little bit difficult because if she can't remember when or what she was treated with.
I forgot to say that she had the non-treponemal antibodies positive throughout the pregnancy, from the first trimester until the birth of the baby.
And the non-treponemal antibodies was do you know what the titer was? Was it going up? Was it going down? Was it very low?
It was stable, and then it was high at the beginning, and then it went down. It was low when the delivery.
And she was treated during that pregnancy?
No. She was treated during, she said, before the first pregnancy and in our country. So we had no documents available, just erratic talking.
So if she had a high RPR or VDRL during this pregnancy, I don't understand why she wasn't treated again. Because I think she should have been.
They proposed a treatment to the mother, and she told me, I didn't go.
Okay, so anybody worried about this lady? Yeah, so I think you did the right thing to do a full assessment of the baby because she, even though she may or may not have been treated before, if she has a high RPR and she hasn't been treated, then she has got a risk of transmission. But if she's not having primary syphilis and she's got more like latent syphilis further down the line, then it's going to be a lower risk. If the baby's completely asymptomatic, you maybe don't have to do a lumbar puncture. You could have just watched and seen what was happening with the serology. But on the other hand, if you want to be sure, it's easy to do a lumbar puncture on a little baby. So, you don't want to put... there's no right or wrong answer, but it puts everybody, I think, at ease to know the CSF is clear.
Okay, thank you.
Yes, we have another question.
Thank you for the very nice presentations, Don Noguera from Barcelona. Regarding toxo, and considering that considering the lack of evidence regarding treatment and that the families and patients struggles with the currently recommended treatment, I want to raise the point about whether we should be aiming to perform studies with sulfamethoxazole trimethoprim to treat congenital toxo, as we have a nice tasteful syrup. We have experience in young kids, and this is a treatment that has been approved for other scenarios with toxo. And I think this is the right place to discuss this. Thank you.
I think, Ton, that is a really interesting question. I think one of the biggest issues is that the prevalence of congenital toxo in the European setting has really declined very considerably over the last 20 years. So actually the numbers of babies being born is very small now. And the other problem is that if you have an asymptomatic newborn, you probably have to wait until they're 15 to decide that they aren't having any recurrence of disease. Because I think what is always the question is whether they go on to get eye disease later on in life. And what we know is that sometimes going through puberty, there seems to be a little blip of children who develop eye disease. So how are we going to design a clinical trial, a randomized controlled trial, I think is going to be really, really hard. But it would be a reasonable and a much more tolerable treatment. If you look at the management of HIV and toxoplasma disease back in the days before we had combination therapy, it certainly wasn't as good as sulfadiazine, pyrimethamine, or clindamycin were certainly above it in terms of efficacy. But obviously that's a slightly different situation. But I think the problem is about numbers. We don't have a European registry of congenital toxo. We don't have good ideas of how many symptomatic, asymptomatic children there actually are. So maybe that's something at least to be considering. But good suggestion.
Okay, now we have a question on... sorry.
Sorry for being late. Thank you for the talks, really been great. My name is Marco Butcher from Lucerne, Switzerland. On the topic of postnatal CMV, would it be worth looking at treatment modalities of expressed breast milk to reduce the CMV load, and looking at different modalities also to get the best out of the microbiome from the mother's milk? Are there any studies going on or any thoughts on that?
Yeah, I think that's a very, I don't know about any studies going on, but I think there is a presentation here at ESPID about breast milk and looking at breast milk DNA. I think I'm not sure if I saw something about that. I think it's a really, really difficult balance. I don't know if there's anybody in the audience here from France, because I think in France, you don't give EBM to babies under 28 weeks I think, so that is, or at least not raw EBM. If you look at the different countries, there are different national proposals of what to do, but obviously that is a tricky balance. I think one of the other important things is that most women in the first few weeks, they don't really have much CMV in the breast milk, and then it rises quite rapidly to a maximum at about a month to 2 months. So there may be a timing issue there, and that is why those babies always get sick on about day 51. It's usually like day 51 or something like that because of when the transmission occurs. So there might be things that we could do in terms of timing. I think it's, giving valganciclovir and ganciclovir to premature babies. We don't have good information on dosing or long-term side effects. The proportion of babies who get really sick is obviously low, but they do get really sick. So I don't think we've got the answer, actually. But more work on breast milk would be good.
Thank you. I am Joseph from Armenia. Maybe I don't understand exactly, but do you mention that 100 of 3,000 of newborns are CMV positive and symptomatic?
Say that again, because I didn't understand. Maybe take your mask off, because I didn't.
100 of 3,000 of newborns are symptomatic and CMV positive symptomatic newborns.
So of extreme prem babies, usually only less than 10% will be symptomatic, and it's maybe 1% who will be very symptomatic. So it's a small number.
It's about newborns from positive CMV mothers or all
So these
population.
are babies who are exposed to, that's the whole population, but it's the babies who are being exposed to positive breast milk.
Yes, and one more question. Do you test for all pregnant women for CMV in your country?
So this is part of the issue, is that most countries don't test women to see if they've had CMV and don't test the breast milk to see what is the viral load in the breast milk. And that might be something that you could do. That's what Michael was just asking. Could you actually test the breast milk to see if the virus is there?
But from where these questions appeared to test milk?
So the reason why we're asking that question is because some babies actually get very unwell and symptomatic with CMV infection. So they can develop hepatitis, thrombocytopenia, respiratory failure, can present like a very septic, sick baby. And as the case here, also potentially necrotizing enterocolitis. But in the past, we didn't really recognize that there was a connection to CMV. We thought it was all just bacterial sepsis, but we now can see that a proportion of those babies, it's CMV that is making them ill.
Okay, thank you.
Now we will take our last questions because we are short on time. Please.
All right, great, thank you. Hello, my name is Marloes, I'm from the Netherlands. I have a question about congenital syphilis. I remember that there's also a guideline saying that you can only do 1 dose of intramuscular benzoyl penicillin. And why wouldn't you choose for that? Because it's maybe more easy?
I think this is from one of the Red Book guidelines, that if you have a mother who you think is going to disappear, and you're not sure about the treatment, but you've got a well baby, you could just give a single dose of IM penicillin. And that is certainly an option, but I think it's considered that, if you have certainly if you have a symptomatic baby, that may not be enough, so that you want to give a 10-day treatment. That IM dose is only given to the baby who looks fine, you haven't got the results of the serology, you think the mother isn't going to come back. Does that make sense?
Yes, it does. Thank you.
So thank you very much, Hermione, for the nice lectures and the great intervention. Thank you to our debaters that are live and online with us. And see you tomorrow morning.